Now the question is you have to see this vertebrae. Each vertebrae has got a body. Now you see a body. This one is body. This is pedicle. This is lamini, and this is transverse process. And this one is the spinous process. So depending upon the body, you see this is on the left side. You see this is from the superior view. This is inferior view. So which part it is lumbar, why it is lumbar? So this is kidney shaped. One thing, vertebral canal is comparatively small, and transverse process is very large, and spinous process is large, and pedicles are also long. So this is pedicle and this is lamini. Now from orientation of the photo, this is from above. The only thing to differentiate from up and below is that this one B, A to F. A you have seen spine, B is the if this is superior view, this is inferior articular surface, this is inferior view, superior articular surface. So C is transverse process, E is vertebral canal, E is vertebral foramen, and F is the body of the vertebrae. Then point out the lamini and pedicle using G and H. So what is this? G is the pedicle, means it is attached to the body. This is pedicle and this is lamini, and this is spinous and transverse process. What are the types of joints? So articulation of the adjacent vertebrae. So two vertebrae are attached to each other. The vertebral arch article, one of the with the superior and inferior articular facets. So these are the articular facets. These are the facets. These are facet joints. These are the facet joints. Synovial type of joint in the sagittal plane, and now this is in the sagittal plane. So this is the plane sagittal. So pathological phenomena affect the joint is osteoarthritis, most commonly osteoarthritis. Which ligaments support the vertebral bodies? Now the vertebral bodies has got this question. Then which ligaments support the vertebral bodies? So each vertebral body has got strengthened by, there is anterior ligament is in the anterior side and ligament is on the posterior side. So this anterior longitudinal ligament and this is posterior longitudinal ligament. Then one ligament is behind. So this is the ligamentum flavum is here. So when you go through the spinal, when you put a spinal needle, it is going like this. So ligamentum flavum, then you get the dura. So what is the composition of intervertebral disc? Now when the disc is there, it has got outer annulus, and in the center there is nucleus pulposus. So annulus fibrosis and nucleus pulposus is the liquid form. Location of then what composition of intervertebral disc? Vertebral bodies are joint intervertebrae which are secondary cartilaginous. So intervertebral disc, this is secondary cartilaginous joint, fibrous and nucleus. What is a common pattern of intervertebral disc prolapse? So whenever there is damage to the nucleus annulus, this liquid material prolapse. Nerve roots commonly affected. So most commonly the nerve roots which are affected are this L4-5 and L5-S1. So there is a maximum. What is the content of nucleus pulposus? It is a gel-like content and collagenous. So it has got collagen, type 2 collagen, mucoprotein and gel-like. You get a picture of this type of vertebrae, and you have to identify which is this vertebra. The important thing is this is the spine, this is the transverse process, this is the body, this is the vertebral canal. So spine is bifid, and this has got the foramen, body is small, canal is wide. So this is a typical picture of cervical vertebrae, and especially C3 to C7. So the C1 and C2 are different. So just keep in mind this is a typical cervical vertebrae. So characteristics type are, this is foramen is triangular, small transverse process with the foramen, wide body, bifid spine. So A, B, C, D already. Now what is the important thing? This is transverse process. B and C, these are the two things. So these are the tubercles. B is the posterior tubercle and C is the anterior tubercle. This is transverse process, this is anterior, this is posterior tubercle. And D is the superior facet joint, superior articular process. So it is articulating with the upper vertebra. The vertebral arches articulates with each other by the way of synovial joints. So how do these arches articulate? These lie almost in the coronal plane, cervical region, allowing flexion. So what is uncus is a small, now fifth, what is uncus and what is the significance? Now what is uncus is a small unturned lip on the upper lateral margin of cervical vertebra. Upper lateral, they form the uncovertable joint successive vertebra and allows rotational movements. And small unturned lip on the upper lateral margin. So upper lateral margin. So there is. Now what is the sixth question? Travels through the transverse foramina. It is a vertebral artery. What are attachments to anterior and posterior tubercle? Anterior tubercle. So anterior tubercle gives attachment to the sclenus anterius and medius. Sclenus medius and sclenus posterior muscle in the neck. Then what is significance of spasa? C7 has got the largest spinous process. C7 has got largest spinous process. Then ligament anatomy of the cervical spine. So there are so many ligaments. Vertebral system, the anterior and posterior longitudinal ligament, and vertebral processes are also joined by supraspinous and interspinous between the spinous process intertransverse ligament. So what is cervical rib? Is a supernumerary rib that is anterior tubercle, arises from the, so it can be from the anterior tubercle, cervical rib. So what does it causes? Cervical ribs causes sometimes compression, anatomic structure, reduced blood flow to subclavian vessels, or it can cause subclavian ski syndrome, subclavian steel syndrome, or stretching of lower cords, nerve roots of brachial plexus. Is little bit smaller size, so it has got thoracic, so it can be especially for the thoracic vertebrae. Thoracic, what is the feature you can identify? So they have got, this one is a heart shaped, body is heart shaped, and canal is circular. This one canal is circular canal. Then what you see is transverse process. This one is transverse process which is angled, and spine is short. Then, and it is generally, when you see from the lateral side, spine is sloping downwards. sloping posteriorly. So this one is posteriorly angled, transverse, and spine sloping downward. So what is, if you see from above, this is inferior articular surface. So spinal nerves, when you see the spinal nerves, there are 31 pairs. So there are cervical, thoracic, lumbar, sacral, coccygeal. So there are 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. So this equal to 31 spinal nerves. So what happens that every thoracic vertebra, so there are 7 cervical vertebra but 8 spinal nerves. So C7, the spinal nerve, it comes from below. Now describe the articulation between rib and thoracic vertebrae. So what happens? This is the ribs. It has got lateral facets. Each thoracic will articulate the pair of ribs by means of demi-facets on the lateral aspect of the bodies. So the rib articulates with the vertebrae at own level and with the above head of the rib, thereby traversing intervertebral disc additionally. So ribs, the line drawn between. So ribs are attached like this. There is one articular surface, then it is transverse process, and ribs are attached in this manner. So what landmarks are performing lumbar puncture? So again, this is the question. What are the landmarks to give the spinal anesthesia or lumbar puncture? So when you see the back of the patient, so this is back, and you are getting the spines, with spine like this. So, and here's the iliac bone. So what is done? This is the landmark, the iliac crest. So supracrestal plane, this is the plane, and you just put a needle. It should be inserted between L4 and L5. So needle should go in between L4 L5. This is the landmark. Then the needle should pass the layers from the first skin, then subcutaneous tissue. So if you see, this is the back, and the vertebrae like this, one vertebra, another vertebra, you get a spine behind. So the ligaments are supraspinous, interspinous, and these are the ligaments. So you go from outside. When you are putting the needle, first you get a skin, then subcutaneous tissue, deep fascia, supraspinous ligament. First is supraspinous, then interspinous ligament. Then what is there? This is the ligamentum flavum. You get, this is the body, and this is here yellow color. This is ligamentum flavum. When you puncture ligamentum flavum, then there is you get here is a dura, and then you get arachnoid. So it has to be dura and arachnoid, and you get the spinal cord. So skin, subcutaneous tissue, supraspinous, interspinous, flavum, dura, and arachnoid. This is the way you go inside. So next question is, what about the sympathetic chain? So the picture of this sympathetic chain is basically, you have to understand that each vertebrae has got, so paraspinal, along the vertebrae there are the sympathetic chain is there. So out of each vertebrae, so when you see a spinal, it has got, this is the anterior and this is the posterior. It has got a lateral horn, anterior horn, and the posterior horn. So from this anterior horn, you get the nerve fibers. Lateral horn, it coming to the anterior horn, you get the nerve fibers. So it goes first. It goes to sympathetic ganglion, and then this is the posterior horn. It forms the sensory. So this is spinal ganglion. Here is the spinal ganglion. This is the sympathetic ganglion. So from here, then this fibers, when they go to the sympathetic ganglion, it has got two gray rami as well as white rami. So this is preganglionic. From there, then it goes to the collateral, another ganglion. From there, it goes to postganglionic to the various organs. So sympathetic supply to from T1 thoracic 1 to L2 level. So there are two ganglions. One is immediate sympathetic ganglion. This is so the ganglions are different. Ganglions are celiac, superior mesenteric, inferior mesenteric. So they supply from stomach, esophagus, stomach, abdominal, liver, and all till the kidneys, ureter, sexual organs, and all that. This is about a station of scapula. You can see the scapula. Now, what you have to identify the specimen of the scapula and which is this side. So, if you see, this is the cavity for glenohumeral joint. So, this, if you are seeing from behind, this is from behind. So, this is right side, and this is you are seeing from front, ventral aspect, dorsal aspect. The important part is this is the spine of the scapula. This is the spine you can see, and it is converting into acromine process. So this is supraspinous fossa, infraspinous fossa, below the spine. This is the acromine process, and you see this is the ventral aspect, subscapular fossa, and this one is the coracoid process. So you get a right side from ventral aspect. Now, what are the questions? Label C2, muscles comprise. So how the muscles are, you have to remember the muscle, supraspinous muscle from here, infraspinous, S-I-T-S. So supraspinous from the spine and inserted on the top of the greater tubercle, and this is infraspinous. Then it forms again the greater teres minor. So, and subscapularis is from here, and it is inserted on the lesser tubercle. So subscapularis cause medial rotation. These all causes lateral rotation. So many movements occur in this shoulder joint, four muscles, tendons, sciatica, glenohumeral joint. So many the movements are forward flexion, contraction, anterior fibers of deltoid causes forward flexion. So subscapularis teres major and infraspinatus. So the painful arc. Painful arc is when the shoulder joint is tied to. This is the scapula and this is the shoulder. When you are elevating it up, so the pain is there. Rotator cuff tear or inflammation that leads to painful arc. So now coming to brachial plexus, it's like this: R, T, D, C, and branches. So it starts from C5, C6, C7, C8, T1. So RTDC, C5, 6 join together to form the trunks, upper, middle, and lower trunk. Then each trunk divides into anterior and posterior divisions. All posterior divisions join to form the posterior cord. Upper to anterior division, this blue color form the anterior lateral and the medial cord. So this one is the lateral cord, this one is the medial cord, this one posterior. Posterior continues into as a radial nerve. Medial cord gives the medial and lateral cord gives the lateral two branches to the median nerve, and this goes as ulnar nerve. This is the median nerve and it forms musculocutaneous nerve. So C5, 6, 7, the it forms the long thoracic nerve of bell, or you call the dorsal scapular, C5, and ventral nerve to subclavian long thoracic. So upper trunk has got branch, upper subscapular, suprascapular, and then lateral cord has got lateral pectoral nerve, musculocutaneous nerve, and lateral root of median nerve. So posterior cords gives 5 branches. Posterior cord. The name are just for remembering is ulnar, upper and lower subscapular, and then thoracodorsal nerve, axillary nerve, and radial nerve. So medial cord, basically medial cord, medial branch, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, and the ulnar nerve. So what are the muscles supplied by long thoracic nerve? It is said the serratus anterior, and then it causes swinging of the scapula. So this one is the humerus. Now this is the lesser tubercle, this is the greater tubercle, and this is the anterior side. If you see capitulum and trochlea. So what you see, the medial epicondyle is always bigger. So this one is a medial side, this is lateral side. So medial epicondyle has got F is trochlea. This is capitulum. So this anastomus, the joint is formed. Here is the head of the radius. So radius head is like this, and then radioulnar joint and trochlea, the ulnar is fitting like this. So this is the humerus, right humerus. The side of the humerus, what we have done is now the next question is identify the bony A to G. So as this is the medial epicondyle, lateral epicondyle, this is capitulum, this is trochlea, then A is the greater tubercle, this one is lesser tubercle, this is the intertuber sulcus. So now what are the attachments at? So here you get attachment of the muscles is like this, deltoid is covering. So here will be the scapula like this, and there will be the ribs are like this. So the pectoralis major muscle, so actually pectoralis major is attached clavicular head and the ribs. So this one is the attachment of H is the attachment of pectoralis major. Then I is latissimus dorsi, it is from the lower side, latissimus dorsi from the lower side. Here is the latissimus dorsi, and J, behind it is the teres major from the lower end of the scapula. So this is the lower end of the scapula, and this is teres major posteriorly. So these three muscles are like this. So anteriorly pectoralis major, this is latissimus dorsi, teres major, teres major. Now how is the next question is, what are the boundaries of axilla? So axilla is a pyramidal space, it's like this. Medially there are the, so there is anterior, posterior, anterior is pectoralis major and minor muscle. Then posteriorly you get subscapularis, teres major, latissimus dorsi muscle. Apex is formed by the cervicoaxillary canal, and base is the axillary fascia. You get medially the ribs and intercostal space, serratus anterior. Laterally you get the intertrabecular groove. So what are the contents of axilla? So axilla contains the artery, vein, nerve. So artery, vein, axillary artery, axillary vein, and other nerves, these are different, but the main thing is actually lymph nodes. So whenever there is pectoralis minor muscle, so it divides. For example, if this is an axilla and this is pectoralis minor, axillary artery is running like this. So in the axilla, and the lymph nodes are divided into level 1 axillary lymph nodes. Here is the pectoralis major, this is level 2 and level 3. So first part is medial to pectoralis minor. So from here subclavian, pectoralis minor, this is subclavian, then it becomes pectoralis, behind pectoralis axillary artery. First part is behind pectoralis minor and it gives one branch. So axillary artery gives the branch. First branch, one branch is superior thoracic artery. The second part is behind, first part is medial to pectoralis minor and one branch superior thoracic. Then here is the second part is behind and two branches, thoracocervical and lateral thoracic. One is lateral thoracic and thoracocervical, thoracoacromial. It goes towards the acromion. And then the third part is lateral to pectoralis minor, has three branches, subscapular, behind the scapula, anterior and posterior circumflex. So artery has got three parts divided by the pectoralis. So first has got one branch, superior thoracic, and second part gives lateral thoracic, thoracoacromial, third part anterior and posterior circumflex, and subscapular artery. So the next question is clavipectoral fascia is a thin fibrous layer around the pectoralis minor. It is pectoralis minor is totally enclosed in it and it is attached to the lower axilla and the apex. So this is attached superior to clavicle, clavipectoral fascia. So it is attached to clavicle and pectoralis minor muscle, suspensory ligament. Structures that pierce it. Important is cephalic vein, then lymphatics, and two lateral pectoral and thoracoacromial trunk. Now the quadrangular space. Again, what is this? You get, for example, if this is scapula, if you see scapula like this, this is the anteriorly. Now this is pectoralis teres major and teres minor. Minor is above, major is here, and you get a long head of triceps like this. So there is one space which is formed, that is quadrangular space and triangular space. So laterally is the humerus. So laterally there is humerus, medially long head of triceps, and superiorly teres minor. Above is the teres minor and inferiorly is teres major. So teres minor, teres major, triceps. So and lateral there. So this is a quadrangular space, passes through axillary nerve. So axillary nerve is like this, and posterior circumflex humeral artery. Axillary nerve in the which nerve can be damaged, fracture of the humerus. The nerve damage, axillary nerve is at the surgical neck, radial nerve is at the junction of ulnar and medial epicondyle, medial and the supracondylar space. So this one is another station which gives the idea at the cubital fossa. You can see this cubital fossa has got a medial, this is the medial side, this is the lateral side, this is the horizontal line, and This is a brachioradialis and pronator teres. So cubital fossa, hollow anterior surface. So biceps brachii. So how are the structures? The triangle is formed. This one is the right, this is the medial side, this is the right. So A to C muscles. Now A is biceps, this is the biceps muscles. Then B is the brachioradialis, C is pronator teres. Then D is the cephalic vein. This is the vein, the cephalic vein, and F is a medial cubital vein. So this is E is a basilic vein on the medial side. This is cephalic vein. So this is basilic vein, this is cephalic vein, and this vein is the medial cubital vein. So this one is a medial cubital vein. Then again I is continuation of cephalic vein. So this cephalic vein is doing like this. And then this is basilic vein. Then H is the brachial artery. This one is the brachial artery. And it divides further into radial and the ulnar artery. So this one is a radial artery. So these are the structures. Now there are lateral cutaneous nerve. This one is the lateral cutaneous nerve and this one is the medial cutaneous nerve. So there are two nerves, lateral and medial cutaneous nerves. This one is a medial cutaneous nerve. This one is the lateral cutaneous nerve. Boundaries of cubital fossa: triangular intermuscular superior line connecting medial laterally pronator teres, medially by pronator teres, laterally by the brachioradialis. Forms the floor. The floor is formed by brachialis and supinator. So the floor, it has to be, this is biceps brachii and this is forming the brachialis and supinator muscle. The roof is comprised of bicipital aponeurosis. So this is bicipital aponeurosis and deep fascia of the foramen skin. The contents of cubital fossa is from medial MBBR, median nerve, brachial artery. So it has to be the median nerve, which is not seen, brachial artery, bicipital aponeurosis tendon, and radial nerve. So medial, brachial artery, biceps tendon, and the radial nerve. So medial cubital vein lines superficial to bicipital. You can see this is bicipital aponeurosis. This vein is superficial. Medial cubital lines related to bicep. It is superficial. Describe the anatomy of cubital tunnel. Cubital tunnel is a roof formed by athletic expansion of two flexor carpi ulnaris. The spine arcades the medial epicondyle of the humerus to olecranon process. Floor is formed by medial collateral of the elbow, expanding from medial body of olecranon to base of. What is the clinical significance of cubital tunnel? Ulnar nerve passes through this tunnel, so it has to be in the medial side. So that leads to cubital tunnel syndrome. So this is the next station, which shows so this one is a station regarding, you get the dissection. This is the thumb, this is the little finger, and this is on the plantar aspect or ventral aspect. So what you see, this is a thenar part. You see a thenar part, and this one is thenar, and this one is hypothenar. So always there are FAO, flexor abductor opponents. So abductor is the most proximal or most prominent is abductor pollicis brevis, flexor pollicis, and there is one opponens. So abductor digiti minimi and flexor digiti minimi. Abduction makes the thumb like this type. This abductor makes it like this. So this is abductor, thenar, hypothenar. And what you see, these are the muscles X, 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 X. These muscles which are terminated at the terminal phalanx are profundus. So you see flexor digitum profundus muscles go deep and insert, and the sleeves are inserted in the superficially like this. So when you see this part, there is the medial epicondyle, there is the lateral epicondyle. From here you get 5 muscles: pronator teres, flexor carpi radialis, flexor carpi ulnaris, palmaris longus, and flexor digitum superficialis. 5 muscles are like this. So identify the muscles level A to J. Now you can see this is flexor carpi radialis on the radial side, flexor carpi ulnaris, radialis, ulnaris. This one is from brachioradialis, and pronator teres has to be like this. Then now this is palmaris longus going straight, A, B, C, D. Flexor digitum superficialis in between. This one is superficialis, which is following the slings. Then from here there is flexor pollicis longus. So flexor pollicis longus goes inside. And then this M is flexor digitum superficialis to little ring finger and little finger. So L is to the little finger, M is to the ring finger. Superficialis, it is attached here, and tip, it is profundus. This one is important. Now flexor digitum superficialis splits to insert into the middle phalanx. So here is the, how is this? Flexor digitum superficialis, it splits. And flexor digitum profundus goes directly and at the tip. So this is the difference. Then to prevent the flexor tendons from bowstrings. So what happens? Flexor tendons should not become the bowstrings. So if suppose these are the phalanx, this is terminal phalanx. Now there are series of fascial covering that anchor the tendon to the bony skeleton. The fingers are the annular, U1 to 5 and cruciate pulleys. So metacarpophalangeal. So this is phalanx and this is metacarpal. So there is one U1 pulley is metacarpophalangeal joint. Proximal is A3 and A5 is the distal. A1, A3, A5. And A2 pulleys over the proximal phalanx. This one is A2 directly on the phalanx. A1, A3, A5, these are the joints. Then A1, A2 is at the proximal phalanx. And again A4 is at the middle phalanx. So it starts from joint A1, A2, A3, A4, A5. So these are the pulleys from proximal to distal. These are the joints and these are on the phalanx. And C1, C2, C3 is between A2 and A3. Then there is C1, C2, C3. A4, 5, there will be C3. So there will be no pulley here, there will be no pulley here, C1, C2, C3. From proximal to distal pulleys are A1, A2. So in between A2 and A3 there is C1. It starts. So there are roughly 8 pulleys. So that bowstring is prevented. Then what muscles, from which Where does musculocutaneous nerve arise from? The lateral cord. Lateral cord continuous. It supplies to the muscles BBC, biceps brachialis, and coracobrachialis. Does the nerve have sensory component? Yes, lateral cutaneous. It continues into lateral cutaneous nerve. Describe the arrangement of muscles in flexor compartment of the forearm. So these are the 5 superficial muscles: frontal trapezius, flexor carpioidalis, foramis longus, superficialis ulnaris, and deep muscles are profundus, flexor pollicis longus, frontal quadratus. What is the nerve supply to the forearm? Flexor compartment. Flexor compartment. Basic nerve is median nerve. So ulnar supplies the ulnar nerve, flexor carpi ulnaris and profundus. What are the actions of flexor nerve, profundus and flexor nerve muscle? How to rotate the muscles? So it is to the tip and this is to the base. What are superficial muscles congenital absent? Palmaris longaris congenitally absent. So coming to the next station, here you get an X-ray like this and you have to identify. This is the thumb. This is 1, 2. This is metacarpals. 5 metacarpals, carpal bones 2, and all this has got 1, 2, 3, 1, 2, 3 there. So 14 merca. This proximal interphalangeal joints. So when you see from radius, so she looks too pretty. Try to catch her. Scaphoid, lunate, tracheotomy, pachyform, trapezium, trapezite, capitate, hamate. So this will be the hamate, and you see this is the hook of hamate. So carpal bones A to H, you are just told what is the mark X. Where is X? This one is X, is the hook of hamate. Joint is marked by the point proximal interphalangeal joint, distal interphalangeal joint. So if you see, this is a palmar aspect, flexor digitum profundus attached here, superficialis is splitting and attaching on the like this. How many carpal bones provide attachment for the flexor retinaculum? So there has to be 4. It is attached in this manner: scaphoid, trapezium, hook of the hamate, and pachyform. Then how many compartments are there in the extensor compartment? Now when you see the extensor, there are 6 compartments. So extensor pollicis, so it starts from this. If you see, this is the back of the hand. Now you see there are 6 compartments. So how to understand this? If you see back, so you see back is always having the extensor muscles. So it is to be extensor pollicis brevis first, then adduction, abductor pollicis longus, abductor, 2 muscles. Then you get extensor carpi radialis and extensor carpi radialis longus and brevis. Then you get extensor pollicis longus for the thumb. So towards the thumb there are 3. Then extensor digitorum, all the digits, then digiti minimi. Then you get extensor carpi ulnaris. So extensor carpi ulnaris and extensor carpi radialis. Extensor carpi radialis longus and radialis brevis. These are 2 and EPB, the snub box. This is the lateral most. 2 muscles of snub box and 1 muscle of the snub box. Radialis brevis ulnaris, digiti minimi, digitorum. How many compartment extents and what turns to each? So carpal tunnel is the ventral aspect. You see the deep muscles. These are median nerve is the and flexor pollicis longus, flexor digitum profundus, flexor digitum superficial is four of them. Risk of damage is always the median nerve and the what is the yellowish shaded area in the dorsum of the hand? So this is the snub box. Extensor pollicis longus. This is the extension. You do this extension and abductor pollicis longus and abductor pollicis brevis. Radial artery, radial nerve, extensor carpi longus, and review the contents of anatomical region 10th. Radial artery, radial nerve, extensor carpi radialis longus, and brevis. Fracture of which bone present tenderness? It's basically scaphoid bone. Complication of the fracture leads to avascular necrosis. Now this is the next. You see the dermatome. How is the dermatomes of the hand? So it starts from C5, C6, C7, C8, like this. C6, thumb is C6. Motor supply to the hand is intrinsic muscles. Intrinsic muscles are supplied by the ulnar nerve. Motor supply to the hand. So it is all the motor supply ulnar nerve except the lateral two lumbricals, opponents, pollicis. So lobe muscles by the median nerve. Three hypothenar, FAO, flexor, abductor, and opponents, digiti minimi. What is the function of interossea, adduction and abduction? What do lumbricals do? Flex metacarpal. This is handing a book or the pain. So the action is like this. And this is the action. Lumbricals do. When you try to hold the book, there is this extension of interphalangeal joint and flexion of metacarpal phalangeal joint. Flex metacarpal phalangeal joint and extends interphalangeal joint. What are the terminal branches of radial artery in the hand? So, pathological enlargement. So, radial artery divides into principal pollicis and radialis indicis. So, here is the radial artery principal. It divides into this now box into principal pollicis and indicis. So, it supplies to the two. And then it forms the radial site of deep palmar arch. What is the clinical name of pathological enlargement of proximal interphalangeal joint and distal interphalangeal joint? So, proximal and distal interphalangeal joint. So, enlargement of this joint and this joint. Pathological enlargement of proximal gives rise to Bouchards. So, this will give Bouchards. Bouchards characterizing rheumatoid arthritis. This is seen in the rheumatoid arthritis. And distal leads to Haberdine nodes, osteoarthritis. So So rheumatoid is proximal, distal is which tendon of the fingers are contained within the sheath? What is clinical significance? Flexor tendons contained in the sheath, and again there are pulleys A1 to A5, A1 to A3. Commonly affects palmar fascia. Palmar fascia leads to tense contracture.